Welcome to Preoperative Clinics Part 2. In this presentation, we will discuss who should go to pre-op clinic. The agenda for this presentation is to cover ASA classification. ASA stands for the American Society of Anesthesiologists. The goal also is to explain which ASA status requires preoperative clinic evaluation and why. And then we will also discuss some exceptions to these rules. So ASA classification, as I mentioned, ASA stands for American Society of Anesthesiologists. It's a classification system wherein patients are classified based on diseases that they have and the severity of their disease. The classification is number-based, so the higher the number, the more complex the patient's history and the sicker they may be. This classification system helps anesthesiologists quickly stratify patients in their mind as being sick versus healthy and high risk or low risk. By doing this, they are then able to tailor their anesthetic technique to the patient at hand. So to go over the ASA classification, this can be downloaded from the ASA website as well. The classification includes 6 number systems, 1 through 6. An ASA1 is a normal healthy patient with no medical issues, does not take any medications for any reason, and has excellent functional status, is able to exercise, do their activities of daily living with no problems. An ASA2 is a patient with mild systemic disease. So for example, this could be someone who has high blood pressure, diabetes, maybe they are active smokers, they are pregnant, mildly overweight or obese. However, all of these medical issues are very well managed, they're compliant with their medications, everything is under control, and there is no functional limitation. So these patients are able to exercise and they are able to do their activities of daily living, again, without issues. ASA3s are patients with severe systemic disease. So they have a complication or a disease of an organ system, a major organ system, but it is controlled and there is no immediate danger of death. So for example, someone who has a history of a heart attack more than 6 months ago, who's obese but morbidly obese, high BMIs over 40, maybe they have heart failure but it's all under control and stable. Again, these patients are compliant with their medications and their disease processes are well managed. However, because they do have severe systemic disease, there's some functional limitations. So they may not be running marathons, they may not be going to the gym every day. However, they're able to complete their activities of daily living without any issues. They're maybe able to go up 2 flights of stairs without any symptoms suggestive of poor function. An ASA4 are patients with severe systemic disease that is a constant threat to life. So these patients have major organ systems that are at risk and they are poorly controlled. So these are patients who, for example, may have had a heart attack within the last 6 months. Perhaps they are active smokers or even former smokers and have chronic obstructive pulmonary disease. Maybe they have heart failure and are symptomatic. It is not under control. And because of this, they have functional limitations as well. So they will be symptomatic with their activities of daily living. They may not be able to climb 2 flights of stairs, so on and so forth. ASA5s are those patients who are at high risk of death without surgery. These patients are not likely to come into clinic. They're most likely going to be in the hospital. So they're very sick. They may have multi-organ failure. They may be septic, have bad hemodynamic instability, and have coagulopathy as well. And ASA6 are those that have passed away. Based on this classification system, you can see that the majority of patients coming in for surgery based on our aging patient population most likely fall into the ASA3 category. It is a very broad category. Going from ASA3 to ASA4 requires specific parameters. So not only does the patient have to have poorly controlled disease, but Even someone with controlled heart failure, but with a very low ejection fraction, for example, less than 30%, would still be classified as an ASA 4. So there are specific parameters that can bump a patient up, depending on their specific disease process. So which ASA classification needs to actually come to clinic for evaluation prior to surgery? Anyone who is an ASA 1 does not need to come to clinic. As you can imagine, they are very healthy, they have no medical issues. An anesthesiologist can see them on the day of the procedure, do a quick evaluation, do a quick physical exam, and proceed. An ASA 2 does not need to come in for evaluation either, assuming that they are compliant with all their medications and have no acute complaints. An ASA 3 should come to clinic to ensure that their medical issues are well managed, that they're on the appropriate medications, again, that they too have no acute complaints, and also that they require no further workup for surgery that is planned. An ASA 4 also needs clinic evaluation for the same reasons as above, and more importantly, to ensure, because they are sicker, that even with poorly controlled disease, that they are at their current baseline and that there's no acute change in their disease process. ASA 5s, again, they're most likely going to be in the hospital. You will not see them in clinic. They do not need to come in prior to surgery. So there are exceptions to these rules. Some patients are very healthy. They may be ASA 1s or 2s, but maybe they're undergoing long procedures or high-risk procedures. And so you may want them to come into clinic just for the benefit of ensuring that any lab work that is required is complete and that the patients understand the anesthetic plan, because the anesthetic plan may be more complicated than a low-risk procedure, and that their questions are addressed. In addition, regardless of ASA status, anyone with a known difficult airway or a history of anesthetic-related complications should be seen in clinic to ensure that those issues are documented and highlighted in the preoperative evaluation so that the anesthesiologist can be prepared prior to the day of surgery.